Good, everybody's in? All right. Well, good morning, everybody, or depending on where you're at, possibly good afternoon or even good evening. My name is Matt Mosores. I'm a data curator here at the University of Pittsburgh. I work alongside Mark and Rich, and if you were attending the big data one this morning, you also I work with Gina McKernan.
Hey, Matt, I'm just going to stop you for 1 second.
Yeah.
Just to make sure. So everybody, this is session number IC 54. The session title is Impact of the Assistive Technology Professional in the Provision of Mobility Assistive Technology. So if you're not in the right room, now's the time to swap out. If you have questions, go ahead and drop them in the chat box. We'll get to them at the end. At the end, we'll also give you the CEU code, and I'll drop that in the chat box as well. And now I will let Matt go ahead and finish.
It's fine. Sorry to jump the gun. Thank you for joining.
It's okay. There it is. All right. Today we're going to talk about a paper that we all have worked on here, me, Rich, and Mark. The effect of assistive technology professional on the provision of mobility assistive equipment. So first, just to kind of get you ready for exactly what we're going to be talking about in here, the study evaluated the effect of client, wheelchair, and assistive technology factors on the client functional mobility assessment, the FMA, scores using the FMA registry by way of ordinal logistic regression modeling. And some of that might be a mouthful, but hopefully by the end of this, you'll understand, especially ordinal logistic regression a little bit more. All right, so a little bit about the FMA. It is a self-rated survey that measures a consumer's ability to function while using mobility equipment. And also because it is self-rated, it's more of a satisfaction than it is really a test of skill. Now, there are 10 activities that they're rated on, and this is on a scale from 1 to 6. I apologize for the mistake in there. That should be a 1 instead of a 0. Now, these activities include daily routine, the comfortability of the equipment, the ease of use to operate, health, ability to reach items, to transfer, personal care, moving both indoor and outdoor, and use of transportation. So of these 10, the individual scores are then added together to get a total FMA score, with the maximum being 60. There are also basic demographics which are recorded, and it goes further than that. So basic demographics such as gender, age, but also things such as living situation, transportation method, and some questions about the wheelchairs and the type of modifications people might have, such as seat elevator. So a little bit of background for this. So typically Medicare is the biggest administrator of mobility assistive equipment, MAE, and they will typically replace scooters and wheelchairs once every 5 years. So it's very important to select the proper MAE for each client, because if it is not the proper mobility assistive equipment, then abandonment of the device may occur. This could just result in frustration for the user, maybe even a lack of trust in the supplier, and if we're talking abandonment, just a waste of resources overall. Now, according to the Rehabilitation, Engineering, and Assistive Tech Society of North America, RESNA, it's Wheelchair Service Provision Guide, Clients who will be using a wheelchair, scooter, or other mobility assistive equipment should be referred to a therapist and supplier who are certified as an assistive technology professional to help them find the correct MAE to fit their needs. So an assistive technology professional is a designation of certification by RESNA, and they are a service provider that analyzes the needs of individuals with disabilities, assists in selection of appropriate equipment, and trains the consumer to how to properly use the specific equipment. RESNA has established a standards of practice for ATPs, and by following these standards, assistive technology professionals can achieve the desired level of performance to help prevent major issues related to MAE, again, such as abandonment. Just some recent relevant literature. Springle and Taylor in a paper titled Data Mining Analysis of Provision of Mobility Devices in the US, which was published in 2019. After doing their own analysis of some of the data sets out there, they concluded that combining the data available from suppliers with prospective collection of client-specific information, such as outcomes, would be a more powerful means to assess the provision of field mobility equipment. All right, so now we're going to get into the paper a little bit. So specifically, our main hypothesis with this is that device type of mobility assistive equipment and the involvement of ATP will be the most significant predictors of the variance in FMA score. Now, for now, don't worry about the variance. Just think of it, they will be the most significant predictors of FMA score, but statistically, we can't say that. So do that. The second hypothesis, ATP involvement is associated with the use of more custom fitted manual wheelchairs in group and 3 and 4 power wheelchairs. Right. So the data that we use for this came from the Functional Mobility Assessment and Uniform Data Set Registry. Now, baseline FMA scores, client demographics, and assistive device details were extracted from the registry for purposes of the study. And I really wanted to underline baseline here because it's not like we did any kind of interventions, things like that. All we took was the baseline scores, analyzed it for trends and to try to see what variables really drove the differences that people experienced in FMA. Now, we used ordinal logistic regression modeling to test hypothesis 1, and I promise we'll get into that more a little bit later. Maximum likelihood estimates were used to identify which values within variables were associated with higher FMA scores. For example, so using maximum likelihood estimates, we could check to see which mobility assistive equipment is better than others, such as a group 3 versus a group 2 power wheelchair. For the second hypothesis, cross tabulations of ATP involvement and device type were used to see if hypothesis 2 is correct. Okay, so now we're going to get into the statistics a little bit here. I apologize for those of you that are not a huge fan of this, but we're going to try to make this as fun and painless as possible. So just going through some of the different types of variables. So scale or continuous variables are things like height and weight and distance traveled. The thing to remember with these is there can be any number in between. Anything that you could think of, whether it's an inch, a centimeter, you can always go smaller, you can always go larger. Ordinal variables. Now, that's a lot of what we're going to be talking about today. So these may or may not be numerical, but there is a certain order to them. The Likert scale, strongly agree, neutral, and down this there. When this is very relevant because with the FMA, everything on that scale of 1 to 6, 1 equals completely disagree, 2 is mostly disagree, 3 is slightly disagree, and then up the scale again for agree. So as we have in there, FMA responses are ordinal. And then we'll do a little bit with categorical variables. There's no rank to these. They are completely non-numerical. State of residence, gender, race, things like that. Okay, so to get into exactly what logistic regression is, I'm not sure how much of you remember anything with linear regression, but just to think is as easy as the slope of the line, that thing you learned back in high school, the mx plus b. The problem is, looking here on here, if you see it has y equals 1 on top, y equals 0. If we are measuring something that is not numeric, for example, this is what was used to teach me this, so I'm going to go ahead with this example. Let's pretend that we are trying to assess the passengers on the Titanic and who survived and predict that. What we know is the person's gender, the person's age, and the class of their ticket. And we're going to try to make predictions based off of that. So looking here, you could see with linear regression, with 1 equals survived and 0 equals did not survive, this line is going above those limits. And we can't have that happen because that's not a possible value in our set. So logistic regression was developed to fix this problem. So now on both sides, you can see we have a boundary at 0 and a boundary at 1. And the way you look at this line, you can almost look at this as a probability score. So as it gets closer to 1, your chances of surviving get higher. As you get closer to the bottom there, your chances of surviving are not as high. And the way things worked on the Titanic, just to give a few examples. So say you were a 5-year-old female with a high class ticket. You are very likely to be one of those dots at the top right and have a 98% chance of surviving. On the opposite end, say you were a 70-year-old male with a lower deck ticket. You're going to be on the bottom left and your chance of survival might be about 2%. Now things get a little tricky in the middle here. Say you are a 16-year-old male, middle-class ticket. You can see where that line is straight for a brief second at the inflection point. There are a few to the left and a few to the right. So there might be a few things that are miscategorized, but for the most part, we are predicting a large percentage of this correctly. Okay, so again, that was with categorical variables. And this can happen with more than 2, with more than yes or no, but it was the easiest way to explain this with a binary. So what we are doing is an ordinal logistic regression. Now we have 6 variables, this has 7, so it's not quite the same. But just as we do with yes or no, along this line, we can predict which response somebody might have for any of those questions. Now, prediction is not necessarily what we did in this paper, but this was just to give an idea of what ordinal logistic regression is and what it can do. All right, so let's go through the variables that we put into this ordinal logistic regression model. First was geographic area. We were given de-identified data through the FMA UDS, and we had 3-digit zip codes. So we used post office regions, which also use 3-digit zip codes, to separate things into a capital metro area, which is basically like DC along the coast down to Georgia, and then Eastern, the Great Lakes, Northwest, Southern, and Western. Device type, this includes everything from canes and crutches to manual wheelchairs, power wheelchairs, scooters, and even no device. ATP involvement. Now this would seem like it would be a simple yes, no, but as we will see later, there is actually quite a large percentage that is unsure. So the 3 options for this are going to be yes, no, or unsure. Primary diagnoses. We left the diagnoses as they are. There are a large number. We'll discuss the exact number a little bit later, but too many to list right now.
Gender, living situation. Now this was either living in the community, living in assisted living, a nursing home, or homeless. The person's age, the age of the device itself, and the year since this person had the onset of their disability. All right, so now we're going to get to some of the results, everything that we saw from here. So this is just going to be basic things, how we saw. So for example, for age, the mean age of people in this data set was 61.12 years old. There's a standard deviation of 17.25 in there. The minimum age was 18 years old and the maximum age was 100 years old. As far as gender, 46.68% of the population was male, 52.88% was female, and a little under 0.5% did not report their gender. As for diagnoses, the most common diagnosis was other neuromuscular or congenital disease, 19.86%, followed by stroke or CVA at 11.45%. And again, we had 28 different primary diagnoses in this sample. Now, ATP involvement, 43.35% had no ATP involvement. 28.19% we weren't able to distinguish whether they did or not. And 28.46% did have ATP involvement. And as far as FMA score, which is the main thing that we were measuring, the mean is 29.57, and that is out of 60 again, so that's like right around the middle. And the standard deviation was 14.91. So now looking into the device type breakdown. 6.83% of people had no device. 19.65 had a cane, crutches, walker, stroller. 40.08% had a manual wheelchair, which is the largest percentage in here. Breaking that down into custom fitted versus non-custom fitted, 12.27% and 27.81. Now for specific things, that non-custom fitted is the highest percentage at 27.81 of all of the MAEs in here. POV or scooter, 2.68. Power wheelchairs overall, 24.27%. The two most common of those were Group 2 power wheelchair at 10.18% and a Group 3 power wheelchair at 12.67%. And then there are a few people where it just was not applicable or not listed, and that was about 6.49%. All right, so all told, we had 4,743 cases of baseline FMA scores to look through. These were collected between July 7th, 2015 and July 20th, 2020. And this is across 300 individual providers. And I think as we will see later, this was also across 43 states in the United States. Ordinal logistic regression modeling showed that age, gender, primary diagnosis, year since the onset of disability, device type, device age, ATP involvement, and even geographic area significantly predicted the variance in FMA score. The only one that we put into the model that did not have significantly predict the variance in FMA score was living situation. And I don't think it is in here, but I can tell you it was extremely close to being significant. And as we predicted in hypothesis one, I believe, device type was the most significant predictor of variance in FMA. So this is just kind of hit home everything that was significant in here. FMA, we have age, gender, primary diagnosis, year since onset, device type, device age, ATP involvement, geographic area, and the most important one, of course, was device type. All right, now going into, this was the maximum likelihood estimates. We don't have to go into that, but we were able to see that evaluations that did not involve an ATP
or where this status was uncertain were associated with a decrease in FMA score. Also, individuals who do not have a mobility device or used a non-custom fitted manual wheelchair were also associated with lower FMA scores. Okay, I know this is a table. Don't worry about the numbers in there, anything like that. The main thing that we want to look at in here is the type of variable, so geographic area at the top. We are looking at Eastern, and for maximum likelihood estimates, we have a comparison variable, and that will be Western. Now, if you're going to look at the rightmost column, the only thing you need to worry about is whether that is above or below 0. So that first one, that is above 0, so we can say that people living in the Eastern United States are associated with significantly higher FMA scores than people living in the Western United States. Now, this is in the model, so all this is assuming that the rest of the variables in here stay the same. The only thing that is different is geographic area, Eastern versus Western. Now, that shows what is significantly different, but there's some more fun things that we can do to this. Now, logistic regression is often used by statisticians, and I'm going to be honest, it is one of my favorite things to use because there are some things that you can have in the output that are really easy to comprehend, and you can make some very generalized inferences from them. So the first thing is a propensity score, essentially the probability that a certain case belongs in a group. If you remember the Titanic example, you can get a prediction of group. So things that were on the top right, as I was saying, would probably be about 98% to have survived the Titanic. Now, what we're going to talk about here in a second is odds ratios. So this is some more output that we can get from any type of logistic regression, not just ordinal logistic regression. But we can get information on how a value within the variable relates to another value. So in this study, we can look at how FMA scores of clients who had ATP involvement relate to ones that did not. And now this is not just the like the previous one, we can actually get ratios to see how much that increases. So the first one we're going to do is we're going to do some continuous variables. And this can be a little bit harder to comprehend than the categorical variables. So for years since onset of disability, the odds ratio in here, what they are saying is that for each year of since onset of disability, you have a 1.01 times higher chance of having an increased FMA score. This isn't going to give us predictions on what the score is. It's only going to tell us whether that score can increase or whether it can decrease. And now this builds off of itself for every year. So this is compounding like your mortgage or your student loans. So if we want to look into the future, if we want to see what things would be 50 years from now, we would take 1.01 to the 50th power. And we could see that around there in 50 years after the onset of disability, you would have a 1.645% chance, or 1.645 times the chance of having an increase in FMA scores. Now, we're going to talk about age here in a second. I have a graph. So this is just to represent how things work with age. So if we were to look at a 10-year-old and track the odds ratios across 50 years until he was 60 years old, it will start at 1 right there. And then as we get to the end, the odds ratio would be 0.575. So if we round that down to 0.5, we can say that after 50 years, you are about half as likely at 60 as you are at 10 to have increased FMA scores. Now, also in that table before, we had some confidence intervals, and I really wanted to do this because you can see at the very beginning, they are very close, but the longer and longer we go, the bigger this gets. Now, the reason I want to talk about this is because we had a lot of people. We had about 4,700 people in this data, but the more people that we get and the more data that we receive, the smaller that we can make that confidence interval.
and the better that we can be able to forecast things for the future with things like odds ratios. Okay, so now this is going to be a little bit easier. We're going to get into some of the categorical variables and how they work. So this was the reference that I used earlier. Western United States is the reference variable, so everything is compared to that. And again, assuming all other variables in the data set were held constant, if one was somebody from the Eastern United States has about 1.5 times the chance of having increased FMA scores as somebody from the Western United States. Now, the nice thing is we can kind of invert these. So rather than going over to Pacific and saying that's roughly 1/3, we can also say that somebody in the Western United States, again, all other variables held constant, has about 3 times the chance of it increasing their FMA scores or having increased FMA scores as somebody who lives in the Pacific part of the United States. Now, going through some of the other things and how these work. Right here we have, so group 5 for power wheelchair is, you can have, you're expected to have significantly higher chance of increasing your FMA scores than if you had no device or a non-custom fitted manual wheelchair. As far as diagnoses, these are all compared to TBI on the right. So somebody who had post-polio syndrome could be expected to have 2.4 times the chance that they would have an increased FMA score over somebody who has a TBI. For gender, and we have obviously a lot of cases for everything on gender, so this is pretty close as expected, although there is a small difference in there. So if we were to assume, round that down to 0.8, we could kind of say that, again, inverting these two, that everything else held every other variable held constant, that if you are a male, you have about a 1.25% or 1.25 times the chance of having higher FMA scores than if you are a female. Now, this is one of the bigger ones. This was one of the main parts of the study as a whole. So using yes as the reference variable, you have roughly about half of the chance of having higher FMA scores if you did not have ATP involvement compared to if you did. And with that number, again, close to 0.8, about 1.25 times the chances of having higher FMA scores if you did have ATP involvement versus if we were not able to distinguish whether you had ATP involvement. Now, okay, yeah, I apologize for all of the colors in here. Right here, this is what we were trying to do for hypothesis 2. We used cross tabulations, and I can say, just working with stats, cross tabulations are usually not fun. We have a categorical variable here on the left. We have a categorical variable here on top. There is not really much that you can do with these outside of saying that the entire table has something affecting it so that each cell is not distributed equally. Luckily, with some of the newer advancements in statistical packages, there is something that we could do, which is a z-test comparing column frequencies. Now, a z-test, think of the bell curve back in the day. So now the way this works is everything in the same row, if it is the same color, that means that they are not statistically significantly different from each other. So using the first one in there, we could see that canes, crutches, and walkers, 30% if you do not have ATP involvement. And that is significantly higher than both unsure at 11.89% and yes at around 10%. But unsure and yes are not significantly different from each other, which makes sense. They're only about 2% difference from each other. Now going into some of the things that we hypothesized. Custom fitted manual wheelchairs we thought would be much higher with ATP involvement. And we can see there that only 3% if you do not have ATP, that is significantly lower than if you were unsure at 12.27%. And that is significantly lower than yes at 26.44%. So this showed that indeed, if you did have ATP involvement, you were significantly more likely to have a custom fitted manual wheelchair. Now, the other one was both groups 3 and 4 power wheelchairs. As you can see for group 4 power wheelchair, there was not many people in any of the groups, only 17 people in this whole thing. So we will focus on group 3 power wheelchair. And indeed, if you did have ATP involvement, you had a significantly higher chance of having a group 4 power wheelchair at 30%, over unsure at 10%, and over no at 2%. So now just to kind of hammer this home, we're gonna go look into here, and don't be fooled by the differences. These scales are different. So the top on here is 10%, and they're gonna kind of move around. So I know these are gonna get smaller and larger a little bit. So again, for no mobility assistive equipment, if you do have an ATP involvement, you are significantly less likely to not have a device at all than if you didn't have ATP involvement or if you were unsure. As far as canes, walkers, crutches, and strollers, if you do not have ATP involvement, you are significantly more likely to have one of these mobility assistive devices over unsure and yes. We went through this before, but just to kind of see it on a graph and see how big the difference is, you're more likely to have a custom fitted manual wheelchair if you did have ATP involvement. Now, this isn't one that we actually tested, but I thought that it was pretty cool. So if we took the people in the data who had manual wheelchairs and took the percentage of those manual wheelchairs that were custom fitted, if you did not have ATP involvement, it was only 7%, up to 32% for unsure, and 65.5% if you did have ATP involvement. Now, again, we did not actually test this, but just looking at the frequencies, I could say with a lot of confidence that all of these would be significantly different. And then adding group 3 and 4 together, these are the percentages. Again, if you did have ATP involvement, you have a much higher chance of having a group 3 or 4 power wheelchair. And I thought it was also just interesting to look at people who got power wheelchairs as a whole out of the entire data. If you did not have ATP involvement, only 13%, up to 22% if we were not sure, and 42% if you did have ATP involvement. I can say again, we did not actually test this, but looking at the frequencies and the percentages, I can say with a lot of certainty that these would be significantly different. At the very least, if you did have ATP involvement, it would be significantly higher than the others. All right, so let's talk a little bit about what all of this means. So this study was one of the first research studies to investigate the relationship between the ATP certification and functional outcomes for individuals who use MAE. And as we just stated, we were able to find that having ATP involvement helps in multiple ways, whether it's finding the correct mobility assistive device for people or mobility assistive equipment for people, or it's just helping overall with functional outcomes. And as we'll see later, I think that we're going to do a lot more with this in the future. Now, again, just reiterating the variables that were significant in here. So device type, ATP involvement, primary diagnosis, gender, age, device age, and year since onset of disability, all significantly predicted in the variance in FMA scores. And kind of going back, I should have touched on this in the beginning. It is important to look at this through a model because we can do some very simple statistics. If you've ever heard of something like a t-test or an ANOVA, and see if these things are significant. And, just thinking of it logically, the better device you have, yeah, you're going to have better FMA scores. Your outcomes are going to be better. But you also have to take into account all of these other things. What is your diagnosis, gender, age? How long have you had your disability? A lot of these things could be known as confounding variables. And you got to really take all of these other things into account so that you can be sure that the thing you think is the most significant predictor is actually that significant. And this model, again, showed that device type, even accounting for all of these other variables, is the most significant predictor of variance in FMA scores. Yeah, as I just said, as hypothesized, device type was the most significant predictor of variance in FMA scores. Furthermore, ATP involvement has a significant effect on the type of device that one has. So even if device type was more significant than ATP involvement has a large effect on what type of device you get in the first place. So it is very important. And finding consumers an appropriate mobility assistive equipment results in improved functional outcomes. And just kind of going back to some of the things, improved functional outcomes, I mean, that's good for the client, but this could also help alleviate client frustration if they don't have the appropriate mobility assistive equipment. And as we talked about earlier, going into abandonment, which would be a waste of resources. Okay, so some of the limitations and some further exploration with this. This is the basic. The sites where the data is collected are not necessarily representative of all the clinics providing mobility assistive equipment. We did have 43 states represented in the data again, and that is still very good. We covered a lot in this, but there's always a use for more data. We can make more accurate predictions, and we can take into account more things, especially geographically, for whatever the 7 states that were not accounted for in here. Some other limitations and some other things I would be interested in is the main part of this study was to see which variables were the most significant predictors of the variance in FMA score. We did a little bit with those odds ratios, but that was really not the main part of this study. And I think that we could do a few more things with that, so we can make some generalizations about which devices are better and exactly by what factor, how much better. Is it having one device, are you 2 times more likely to have a higher FMA score than having another device? I think that's something that we could do with further exploration. Also, with some future work, we can examine the involvement of ATP and other factors affect the outcomes of the service delivery process over multiple time intervals. Now that's important because this one was only baseline, but as we talked about earlier, the FMA does have follow-ups, so we can look at how these progress over time, maybe even evaluate the training that these professionals give to their clients on how to use their equipment. Comparing multiple data sets across a diverse group of stakeholders, including a wheelchair repair registry, supplier business operations data, health insurance wheelchair claims, and data provided by a manufacturer's connected wheelchair. That is a whole lot of different things. The nice things about these is maybe these data sets might not have variables that are related to each other. But for example, taking something from the wheelchair repair registry, finding out how much something costs, and then relating that to maybe outcomes with a certain share. We can make some inferences and combine these sets together to really get a big picture of everything that's going on. And analyzing the effect of power wheelchair modifications, such as a seat elevator on FMA score. And just to conclude, again, I know we talked about this, but just to reiterate, device type was the most significant predictor of FMA scores, as well as the US region, ATP involvement, diagnosis, gender, client age, device age, and year since disability of onset. And ATP involvement did result in higher proportions of people using custom fitted manual wheelchairs and groups 3 and 4 power wheelchairs. And I feel this study, along with future analysis, can help in providing strong scientific evidence to advocate for the involvement of assistive technology professionals and justify the need for higher quality mobility assistive equipment. I just want to end on this by saying I know a lot of the stats end. I'm kind of new, not very new, but somewhat new to this particular job and to these particular projects, dealing with wheelchairs, some of the modifications, assistive technology professionals. So I had to go to some people to learn more information on this. And just from talking to them, I've kind of learned that some of the things that we talked about in here, again, that if you have a better device type, you're going to have better outcomes, or you're going to be happier with your equipment. I mean, that seems just too logical. Like, of course it's going to be like that. But if we want to change some things and see that actually come to fruition, people get mobility assistive equipment that is tailored to them and the highest quality that can help them out. Actually doing some studies like this with concrete numerical evidence, I think will go a long way to achieve. And that is everything.
So Matt, so we have a question in the chat. Kyle's asking, do you have any inferences into why there are higher FMA scores as you move east across the US?
I am not quite sure of that. I'm trying to remember exactly what were in there. I can say this, Pacific was one of those that was associated with lower FMA scores, and the Pacific region only included California and Hawaii. It's very possible that there weren't a lot of cases in this data set in there, so that can affect how well those numbers were. But I would, if I had to assume, I think it has to do probably with the quality of assistive technology professionals in hospitals. It's not as much about the stats. That wouldn't quite be my expertise. That would be either Mark or Rich that are here with me.
And a follow-up to that, also based on this data, do you feel that we as an industry, are now ready to sit at the table and discuss changes in a provision policy with stakeholders, perhaps UPMC?
I think we need to do some more. I think this is a good start, but there's a lot more things that we could do, and especially if we're talking about stakeholders, UPMC, insurance companies, things like that. I think we need to do some things that involve cost to maybe show certain things that we can save them money, both in patient outcomes and in repairing wheelchairs the correct way, so they don't keep having small things that need to be repaired. I think, honestly, as terrible as it is to say, I think that's probably going to be the main thing before we really take it to places like UPMC.
Okay, so I know we're a little ahead of schedule, but I'm going to go ahead and drop the CEU code into the chat for those of you who need to leave. Oh, wait. And a couple of well done's in there. Oh, Julie's asking, is there any information in your ATP data for those ATPs are also SMS certified?
There's not, no.
Okay, so the CEU code is XGDOJJ. And I'll drop that into the chat for y'all.
I just wanted to step in here and say thank you, Matt, for putting this presentation together. So Matt is a data scientist, works down here in the department, and we got to congratulate him. This was his first ISS presentation and his first conference presentation. I think he did a fantastic job. So thank you, Matt. And thank you for being part of the team. I'll just add to, as we know, Matt is very good at looking at numbers. A lot of this is still hard for me to wrap my head around sometimes too, but I think your analogy of the Titanic is a valid one. So my takeaway would be that your survival rate depends on what type of wheelchair you get and whether or not an ATP is involved. So I think talking about what we could do with this, we're just scratching the surface. This was one of the first analytics we decided to run. It was fairly simple to do because we could sort of split up the data between ATPs, no ATPs, and we found a lot of interesting things. It doesn't always mean like, we're looking at West Coast versus East Coast. There's too many other variables that could be impacting that. And even though, we have 10,000 baselines as our control group right now, it's still not a lot when you think about it. And it's not covering the entire nation for sure. If we do see a disparity like this and we're not sure what it is, we start to look at other factors and other variables. Maybe it's that where this data was coming from, the payer is not cooperative, or there's a higher level of denials, or maybe there's differences in practices. Maybe it's climate. Maybe there's just so many other variables that can muddy your analyses, and that's why large data has to be large so that you can start to control for things like that. So this is just the beginning. Matt and Gina and that whole group is going to be with us for a while. We're fortunate to have them because they can take this data. I can look at it. I can share it, the descriptives, and say, hey, look, these are the differences between variables. But until the statisticians get in there and actually run those analytics that are often very complex and foreign to us, but I think what's nice about it is what Matt and his group has done here is showed that, beyond, I would like to say, like it's obvious that there's better outcomes. Whereas the statisticians say it's very likely that if you get X, Y, and Z, or you have X, Y, and Z, your outcome is going to be this. So if you're on the Titanic and you're a 5-year-old female in first class, you have a 98% chance of survival. It doesn't mean that people who are living in steerage or riding in steerage and are older males aren't going to survive, but we get these odds ratios pretty much saying that, what we do, and in this case it's CRT, what we do as ATPs makes a difference. And looking at payer sources and policy, we certainly showing them these analytics, they're not going to tell us that we don't know what we're talking about, or that what you're saying is not truthful. It's pretty certain. So what's nice, Matt, thanks, is that what you showed us scientifically, statistically, does align with common sense. So that's, at the end of the day, what we see on the street, what we believe we know, you're just sealing the deal here. So now when we do go to policymakers, we're not just saying, hey, you need to pay for more things that are better, but here's the stats to show that it really does make a difference. And I think that's where we're driving home some policy changes as much as we can, even here with our own payer, for instance, at UPMC, to say, if we do things like put people in better quality equipment, reinforce that ATPs have to remain as part of the policy. We want to add other things to our policies, that it's not just raising the cost, but it's resulting in better outcomes, saving people money, allowing people to live in the community, and all the things that we want to do with this information. So I don't know if there's any other questions that have come into the chat. We've got about 10 more minutes here if anybody wants to have some further discussion.
There was a question that came in, but someone addressed it. I'm assuming Matt addressed it in the chat. So the question was, I'm assuming that ATP involvement meant supplier ATP and did not include clinician ATP. Can you confirm?
Yeah, well, that's a good question, because as we were putting this uniform data set together, we didn't want to get too granular because that would just make, I mean, people are already complaining they don't have time, right? Like, I don't have time to collect outcomes. I don't have time to do this. If we made our process too specific, it would result in longer forms, more things to fill out. We can assume that based on where this data is coming from, that probably 90% of them were suppliers. Now, there are clinics participating in this registry. So, you know, Ohio State is one example. It's probably both in that case. The clinician and the supplier were ATPs, but you know, for sure, we know that the majority of the supplier was an ATP. As far as the clinician, we don't know whether they have their SMS or not. We don't know. Can we add that later? Sure. We'd like to add that to the uniform data set, but let's first get people to get used to collecting data before we start adding more things that they'll perceive as just more burden and less likely to do it.
Okay, there's
Anything
another
else?
question. How can we as an overall group, meaning including everyone, or just suppliers, get more involved to get better outcomes? And why do you think collecting this data is difficult?
Well, personally, I don't think it's difficult. So, but that's my biased opinion. We tried to keep this as simple as possible. Much of the information that's being collected, you know, if you look at the 10 items of the FMA, those are all things, those are all themes that we cover in a thorough assessment anyways, you know, comfort, how do you get around indoors? We're just asking people to put a number on it. Personally, when I do the FMA, my evaluation is shorter because it's a pointed question. A response is certainly a lot of subjectivity to it, but I also say, give me a number. Kind of like if a practitioner is asking you about your pain, you could go on and on trying to describe your pain, and then they'll say, give me a number, you know, on a scale of 1 to 10. So it's not that burdensome. We intentionally tried to make it as simple as possible. This whole process was developed by clinicians, for clinicians, or with suppliers, for suppliers. It wasn't it's not an onerous process that was put together by, you know, some managers somewhere or some government officials somewhere. It was really designed to work in the clinic. So I don't think it's that burdensome. And even if it does add a few minutes to the process, I think it's a big return on investment. Just, you know, by example of today's presentation and an analysis, it's showing that, yeah, we pretty much confirmed beyond a reasonable doubt that ATPs are valuable and suppliers with their ATP are valuable and therefore should get the respect, the remuneration, and everything else that goes along with it. Unfortunately, policy doesn't always see it that way, but here's just added evidence to kind of elevate or demonstrate the value of an ATP and also the value of high quality equipment. And obviously from this analysis, you're not likely to get access to high quality equipment unless there's an ATP involved.
So a follow-up to that, Mark, do you feel there are potentially more efficient ways to automate these surveys and use technology built into an EMR to escalate or intervene with a patient based on the delta in a patient's FMA scores?
Yep, that's all stuff that we're working on. We had to start somewhere, and we're kind of in the early Stone Age, I guess. You know, we're using paper, we're using the you know, simple electronic resources, but we do see a future where this UDS, FMA, and other outcomes are baked right into the electronic health record. And then that way it can be extracted, de-identified, and transmitted for analysis like many other areas of healthcare. It's just been a matter of what the resources we have, the priorities of health systems. But I will say, I know on our end here and with our payers, you know, anything that you can do to bake your outcomes right into the electronic health record is certainly going to be helpful. And I also think that with the shift now to you know, patient-centered outcomes or person-centered outcomes, and a huge shift to keeping people home in the community versus in the hospital, these are all things working in our favor. So we're getting there. But absolutely, we see a day very soon where it could be a simple app where client fills it out in advance, it transmits, or they could do it in their health portal. They could get their follow-ups through text messaging in their health portal, add the data into the EHR. The EHR exports to a registry for data analytics. So we're getting there.
And then there's another follow-up, which I think, if I'm understanding this correctly, sounds like David's saying that this is invaluable, yet everyone I hear an opinion from, someone like you, I hear weak numbers. And like you said, and most people say, don't have enough time. So again, your opinion, how can we get more data? What is it going to take?
That's a $1 million question. So I hate to say it, but oftentimes we don't do stuff until we're told to do it is one. If I look at, any other profession, if we look at like FIM, for instance, back in the 80s, none of us wanted to do it. And then Medicare told us we had to do it. We did it. And after a while, we didn't realize we were doing it anymore because we were just doing it. It was part of the routine. I think when people start to see the value of the analytics on the back end, they're more motivated to do it. It's just like a lot of things right now, even the connected wheelchair. What do we have to do to get people to turn that on, share their data? What do we have to do to get the clinicians and suppliers to buy into it? It's basically, it's change, and people don't like change. Even myself, I don't like change. So it's just something that has to happen over time. So we got to show what are you getting out of it? And I think what we're getting out of it is stronger evidence that what we do works. With that stronger evidence, hopefully becomes better policy. Right now, we're kind of chasing cuts in reimbursements versus someone saying, hey, what you guys do is valuable. Group 3 power wheelchairs versus no wheelchair, or higher end wheel like group 4 power wheelchairs. They're not even covered because no one sees the value. No one sees the value of leaving the home and being able to do things in the community. That's all going to change now that we're moving to a more community-based accountable care system. But again, we have to show our value. So
Julie commented that she would love to see an additional expansion on this. Is there a difference when the ATP involvement is physically in person versus remote? Lots of opportunity here, exciting information, in my opinion.
Yes, and thank you, Julie, because what we did add as soon as COVID hit to our UDS anyways, there is an additional question. Was this in person or was this over telehealth? And we'll be hopefully running analytics on that fairly soon once the sample is large enough. We've done other studies using the FMA UDS, not in this data set, but others, like our VA research compared FMA scores, telehealth versus in person, and there was no difference. They were equally the same.
All right, and that is just about time. We have about another minute or so left. So at this time, again, I'll drop the CEU code into the chat. If there's any other questions, drop them into the chat. The session's being recorded, but thank you, Matt and Mark, for all the information today. And make sure you check out the exhibit hall over the next hour and a half or so and see what's in there. And thanks for coming.
Yeah, thanks, Matt.
Thank you, Mark. Thank you, everybody.